Thank you. My name is Jakob Steiner. I'm a radiologist at our university center here, and I'm going to show you some cases. I won't take too much time because, as you might know, the most important thing about ultrasound courses are the hands-on courses. I have nothing to disclose here. Great questions from the audience so far. Like Jasminka said, from a radiologist's point of view, you can get the feeling that every patient who is going to be an emergency patient will receive some sort of CT after eFAST. But a more accurate view is this little image I found. So you can check on patients after eFAST with structured sonography, but you should when you yourself are performing eFAST. The first patient is a 65-year-old male patient. He was in a car accident. His car got hit by another one, and the EMTs tried an load and go approach. So at first he was stable in the emergency room with minor scratches and a little bit of neck pain. Blood pressure was normal, no shortness of breath. We started with the subcostal cardiac view, a little video here. What you might see is a little bit of fluid right in front of the right ventricle. That is totally normal. So when you see a little bit of fluid around the heart, it isn't always something traumatic. It can be physiologic as well, depending on the age and the pre-existing conditions of the patients. We took a look at the upper right quadrant inside the Morrison pouch. As Jasminka showed you, we see a homogeneous liver parenchyma, we see the diaphragm, we see the kidney, we see Morrison's pouch with fatty tissue inside, no sign of free fluid, a little bit of fatty liver disease maybe, but nothing too special. And then we did the upper left quadrant view, the collar realm, collar pouch. We see the spleen, homogeneous in its parenchyma. We see the kidney with the classical appearance of the kidney bump and some fatty tissue inside of the pouch. No signs of free fluid. Pelvic view, I don't have a video of that, but you have to believe me, there was no free fluid. And then a pleural view with the classical running of the ends, moving of the pleura. This is a very basic and very common case for every emergency room because there was no sign of free fluid. The patient was under surveillance. CT showed no signs of intra-abdominal or intra-thoracic injury, and the patient was discharged just 3 days later. Why I'm showing you that is because a lot of the cases are negative eFAST cases, so you should be confident about seeing something that is normal and something that is not there, like when there is no free fluid. So get a hold on the normal anatomy and feel confident with negative eFASTs. The second case is a 20-year-old male patient who crashed his bike into a fence, which I would never thought of as a common injury, but it is a common injury. He had no neurological symptoms and he had complaints of vague abdominal pain. On physical examination, the abdomen was soft, no resistances, and he was stable in general. So first step, eFAST. The subcostal cardiac view, was kind of difficult because, as you can see, he was pretty filled with fluid. These are veins and arteries. We see the left part of the liver, but we couldn't get a hold of the cardiac view. As Jasminka told you, it's sometimes really hard, I think, especially with thinner patients and younger patients, to get a proper look at the heart in an emergency setting when the patient isn't lying comfortable. You can't just move him around. Sometimes you have to report you can't see the subcostal view, you can't see the heart. In the right upper quadrant view, we identified some free fluid, so you can see the lower border of the liver, you can see some parts of the colon, you can see the kidney, so we know we are in a Morrison pouch, and we identified a little bit of free fluid. When we looked further up, there was a little bit of free fluid there as well, but no diaphragm fluid, so we didn't find anything there. And the kidney in general looked fine, so no signs of damage to the liver or to the kidney. When we looked at the upper left quadrant, we identified a hyperechogenic line inside of the spleen, and this huge region, which was just the stomach, so not a big deal here. We see the hilus region of the spleen with a lot of fat and vessels inside, but no free fluid. Due to this little hyperechogenic line, we did a Doppler sonography and showed orthograde vascularity of the spleen. And then we took a look at the kidney as well, with no signs of injury and no signs of free fluid in the collar pouch. When we take a look at the pelvic view, we might identify some free fluid here on the lateral edge in the right side of the patient, adjacent to the bladder. And when we looked further up, like at the top of the bladder, we identified even more fluid surrounding some of the bowel loops. The pleural view was nothing special. We see a seashore sign. I don't have a video, but there was a normal movement of the pleura. And our diagnosis was a eFAST that was positive, so we identified some free fluid. The patient was stable, and we weren't sure if there was splenic trauma or not. So in a stable patient with a positive eFAST, the next step wouldn't be surgery, but CT. And I'm going to show you the CT scan. So when you take a look, this is an axial view in a portal venous phase. So we see in this windowing no signs of pneumothorax. Heart looks fine, so we see no signs of pericardial effusion. Liver looks fine, and then on the left side here, we see the spleen with hypodense regions and more like a scattered appearance, which is highly suggestive for splenic laceration. But we saw free fluid in our eFAST-Protocol, so we have to take a closer look whether or not we see free fluid, and we really could identify this little collection of free fluid at the bottom of the liver, which was perfectly comparable to the ultrasound. And when we took a look further down, we could see even more free fluid here in this case in the Proust pouch. I have two different planes for you. So this is a coronal plane, same phase. We see the splenic laceration on the left side and a little bit of free fluid down here to the liver. Sagittal view, free fluid adjacent to the liver. Sagittal view, splenic laceration. You can classify everything in radiology you don't have to remember that. In this case, it was a grade 3 laceration. Case 3 was a 26-year-old female patient with a blunt trauma to the upper left chest and abdominal pain due to a sports injury. She was kind of short on breath. On palpation, the abdomen showed no resistance and was soft. So no major signs of injury. The patient was stable. So we did an eFAST, cardiac view, showed nothing. Right upper quadrant view, we see not the best images, but we can identify the liver. Here we have some sorts of artifact. We see the kidney, we see Morrison pouch, no signs of free fluid. We see upper left quadrant view, we see parts of the spleen, we see the upper poles of the kidney on the left side. We see Collas pouch, no signs of free fluid. Pelvic view, no signs of free fluid. And when we did a pleural view, in this case, on the left side, we can't quite get the feeling that there is movement of the pleura. So we compared it to the other side, but it was quite nicely shown the running end sign with the movement of the pleura. And for comparison, here on the left side, and here on the right side. So we were highly suspecting pneumothorax in this case. And it was a very small pneumothorax on the left side in the upper part of the lung. So you can see here is a small line, in this case a little bit bigger. This is the pleural line, and I can show you here with a little marking. A follow-up ultrasound showed a little hematoma adjacent to the 7th rib with a cortical fracture of this rib. I can't guarantee that in this case the rib fracture was like the cause of the pneumothorax, or it could just be the trauma itself, but the rib fracture wasn't visible on X-ray. So ultrasound, in addition to being a great way to treat a emergency room patient, is always quite a nice modality to look for rib fractures. The patient was followed up and showed after 3 days no signs of pneumothorax anymore, so she was discharged. You have to stop me if I'm taking too long. Case 4 was a 47-year-old female patient. She was hit by a car going at low speed. In the ER, she was stable with minor trauma to the head, no abdominal pain, no shortness of breath. These are your standard eFAST cases. Right upper quadrant view, we already know liver, kidney, Morrison pouch, no sign of free fluid. After upper quadrant view, we get a really nice look at the spleen and at the upper poles of the kidney, collar pouch, diaphragm, no signs of free fluid. Pelvic view, little bit not the best images to take a look at. We see the filled bladder, we see the rectum area, and when we took a better look at the pelvic view, we saw the bladder and the uterus, and behind the uterus we identified a little bit of small fluid collection, around 2 centimeters. And in this case, the patient was followed up because she was stable with CT. And the CT, I'm only showing you this slide, showed a little bit of free fluid in the Douglas pouch behind the uterus, very nicely filled bladder. And due to missing trauma in general in the abdomen, you can identify collections like these as physiological. So free fluid in the Douglas pouch in women, especially up to the age of 60, is totally normal. You have to correlate it with clinical findings, with history, and with the situation of the patient in general. So no abdominal injury. She had minor bleeding in the head due to her head wound and a little bit of free air due to a skull fracture. And our last case, before I let you try out yourself, is a 40-year-old male patient. He was driving his car during the evening and he lost control due to unknown reasons. He was drunk. So it's probably one reason, but we don't know why he in particular lost the control. The car went off the road and he was injured while not wearing a seatbelt. In the emergency room, his Glasgow Coma scale was 14, circulation was stable, no shortness of breath, but he rapidly declined in general and was later intubated. When we took a look at the upper right quadrant, we identified free fluid in the Morrison pouch. So we see the gallbladder, we see the liver, we see some parts of the colon and a little bit of free fluid here. Upper left quadrant, I only have the Doppler images. This is part of the spleen, kidney, no signs of free fluid in the collar pouch. But when we took a closer look, a little bit further down, we identified a huge collection of free fluid adjacent to the spleen. Pelvic view, a lot of free fluid in the pelvis. You can very nicely identify the small bowel loops here just swimming around in the free fluid. And our pleural view was like this. Nothing. We couldn't get a hold of it. We couldn't see anything pleurally. Not in M mode, not in B mode. So we weren't quite sure, okay, what's the cause of this? The patient was stable in the first place, so he underwent CT scan. And this was his CT. So we are starting with the abdomen. Oh, works. Okay. So on the left side, you can quite nicely see a total rupture of the spleen. We can't really identify the spleen in its entirety. It's more like a huge hematoma. And we see these little strings of hyperdense material, which showed us an active bleeding of this area. So we had a total splenic laceration or rupture with an active arterial bleeding. We identified another collection of free fluid around the liver. And when we got further down, we identified a little bit of free fluid. But in this case, it wasn't quite nicely seen here. Maybe due to the repositioning of the patient. So when you see free fluid in the pelvis and you lie the patient on the CT scanner, it can move, it can freely move. So it might just be a little bit different in the CT. But why couldn't we get a hold of the pleural view in eFAST? It was due to this. So he had a huge pneumothorax on the left side and he was having a lot of free air in his subcutaneous fat and between his muscles. So he had an emphysema, and this was causing huge artifacts because, as you can imagine, our ultrasound waves can't get through the free air in the subcutaneous fat. So we weren't able to identify or to get proper pictures during the eFAST, which is important because in first place there was no signs of pneumothorax clinically, but when you see artifacts and when you really can't get a hold on the pleura, you might think of emphysema as a condition underlying that. I'm just, for completion, I'm showing you the the bony fuse, where you can identify a lot of rib fractures due to the accident here, very displaced rib fractures. So we have a massive splenic rupture with acute arterial bleeding. We have a left-sided pneumothorax. We have subcutaneous emphysema, and we have rib fractures and some more, which I didn't show you. The patient underwent surgery for splenectomy and got a chest tube, and is currently at the intensive care unit. What I'd like to point out, there are some pitfalls for eFAST, especially situational pitfalls. As you can imagine, an emergency room is always very crowded, and at some point you will do eFAST and you will do eFAST for the first time. So don't let the situation get ahead of you. Be confident, take your time, you know how to do the eFAST. Just do it step by step. The patient positioning in the emergency setting can be quite difficult. When you try it out in the hands-on sessions, you can tell the patient to lie on his left, to lie on his right, to get a proper view to the organs, to the pouches you want to identify. So in some cases, in the emergency setting, it's really hard, and just ask for help. Ask the nurses, ask the other staff to move the patient if you can't see the spleen or the collar pouch, which is usually, at least for me, the most difficult, or the one difficult thing about eFAST to really master. There are some different artifacts. I couldn't get into all of artifacts in ultrasound, but when you go to Sono4U courses, you will learn about a lot of artifacts in ultrasound. There are some mimickers, as Jasminka already showed you, or the great question about the ascites, the free fluid in the abdomen with pre-existing conditions, which she greatly answered by just look at the patient itself. Basic anatomy can be challenging. Everybody of you has heard about situs inversus and stuff like that. Know that sometimes there can be rare things, and be aware that it isn't always true what you might see. And of course, probably the biggest thing in ultrasound in general, experience is everything. So don't be too sure if you're not that experienced, because sometimes misinterpretations, especially in eFAST settings, can happen. My take-home messages for you: get experience. You can read books, you can go to talks, to courses, all you want. Experience, especially in the emergency setting, is the most important thing. And don't be too hard on yourself. Everybody starts at some point. I know when I did my first few eFAST ultrasounds in the emergency setting, it's not fun when you're responsible for it, but you will get better. And the only really important thing is to know when you need help and to know when to call for help. You can get some knowledge on homepages like Radiopedia, which is a great source of information for anything radiology related, and pages like POCUS 101. And the most important thing for me, you're at the start of your career, have fun. It's great working in medicine. Learn and have fun. I'd like to, before you applaud, I'd like to thank a few people. I'd like really to thank Jasminka for being there always. She's my mentor, she's my teacher. And of course, Sono4U for organizing not only this summer school, but organizing a lot of great peer teaching. Now I'm finished. Thank you.
Thank you very much for this more practical view with the clinical cases. Does anybody have a question to our radiology consultant? Yeah, sorry.
Because
I repeat the question. It was about the last patient, why they didn't go to the operation room directly and took a CT.
that's a great question. In this case, it was a rather recent case. It was during the nights. He wasn't that unstable. He continuously got worse. And when the emergency trauma team decided for CT, he was in an okay state, but right after CT, he went to surgery. But those are the cases where, at least for our center, usually they are not that proactive going to surgery, but the surgeons want to have a better view than just the eFAST. eFAST is a great early assessment for any sort of trauma patient, but if you want definite answers, you need your radiologist and you need your CT.
Any other questions? Yeah, in the back. Okay, I repeat the question. It was about how much time can you take for doing an eFAST scan, and is it more better to be quicker or precise? What's the best balance between that?
Okay. That's a radiologist's point of view. You take the time you need. There is no time limit. It's great if you finish in 20 seconds. It's great if you finish under 1 minute, but your examination is important for the next steps and for the further steps. So if you have a trauma leader who is very excited and he wants to get it done and go, what's the eFAST, positive, negative, take your time. You are doing the exam, you need to be sure what you do. You shouldn't take 10 minutes. You shouldn't try to identify all the liver vessels, see if there's free fluid, and in a very unstable case, if you can't identify free fluid or if you can't be sure because you can't get a hold of the pouches, just tell the patient, the trauma leader. Be honest. If I don't see something, I tell the trauma leader I can't identify the heart. I don't see it. If he's stable, he goes to CT. If he's unstable, they need to operate anyway. And what was the second part of the question?
The balance, the best balance between the quickness and the for the duration that it precise. Yeah, the precision of the views.
Was it answered? Yes, great.
Yeah. So does anybody else have a question? Yeah.
Can you perform a follow-up CT on an unconscious female patient, or do you have to make sure first that she is not pregnant?
In an emergency the question was whether or not you can perform a CT scan on an unconscious female patient where you don't know if she's pregnant or not. In the case of emergency, you always do the CT. If it's necessary, you do it. Of course, there is the possibility for radiation damage to a fetus, depending on what stage the fetus is at. There's great literature on what point during pregnancy you can apply what radiological examination, but in the case of an emergency, you do the CT.
All right.
There is one more question from our online audience from Latvia. If we can't identify a certain structure in eFAST, how much time do we have to look for it before moving on to the next part?
It depends on the whole situation. If the patient is stable, I take a little bit longer, but usually, like Jasminka said, I really aim to finish before 2-minute mark.
Okay, so that's it. So thank you again, Jakob.